welcome the rest of the members of the Geriatric Hub team, which include our advanced practice nurse, Courtney Nunokawa, pharmacist, Chad Kawakami, our psychologist and guest speaker, Lucas Morgan, and of course, our geriatrician, Dr. Rita Bell Fernandez. As a kind reminder, we have evaluation forms for those persons interested in receiving CMEs, and it is required that you complete the evaluation in order to receive the CMEs. You will be able to find the evaluations by following the link in the chat towards the end of this presentation, or at any time on our website and email advertisement that you see in front of you. Your comments are very important to us and feedback on these evaluations. It really helps us as a planning committee look at future programs. With regard to about ECHO, we want to emphasize that this ECHO webinar serves as a forum for mutual teaching and learning from experts and from each of us on the front lines, which is you. As our motto goes at ECHO, all teach, all learn. So it will take all of us to create a community of learning. Our webinar format consists of a short lecture from our expert presenter, followed by open comments from the expertise of the ECHO Hub members I've mentioned, and you, the attendees, participants, comments, questions, and case examples are welcomed. Additionally, we invite you to share any specific geriatric cases, and we ask that you please keep the case discussions HIPAA compliant. This includes not sharing the patient's name, birthday, address, and so on. We learn best from our patients and our clients. They are our best teachers. Today, it gives me great pleasure in sharing with you and introducing Dr. Lucas Morgan, who sits on our geriatric hub. He has a very colorful CV, but I'm going to just briefly say that Dr. Morgan is originally from Hawaii. He left to pursue his studies in mindfulness-based behavioral therapies. He later returned to Hawaii. He completed an internship that focused on mental health in underserved rural areas and with Native Hawaiian adults, their families, and of course, with a passion working with our elderly care organization centers and local agencies on aging. Presently, he is employed with I'Ola Lahui. It's a behavioral health program, and he's involved with supervising a number of doctoral fellows. He's had numerous publications that he's presented, but again, I think this topic that he will be speaking to us about really will engage us with meaningful dialogue. So without further ado, I want to welcome and thank Dr. Morgan.
Thanks so much, Sarah. And thanks so much, everyone, for joining us today and showing up for a little bit of hopefully some discussion about ageism, which is something that I think a lot about working as a psychologist with older adults and sort of with social justice in general, and thinking about how ageism fits in with identity development and with healthcare and how it can change the care that's provided, but also how older adults see themselves, their futures, and how that can also change behavior and health outcomes. So I want folks to keep in mind that this is going to be most useful, in my opinion, if you take this personally. Okay, it's easy to intellectualize about things like ageism as something we can think about out there, and yet all of us are socialized from day one to internalize stereotypes about different groups. That's just the way that we work, we categorize, and the way society classifies different folks. And older adults, as we know and as we'll explore, have a number of negative stereotypes attached to them that affect providers, each of us. and our own aging process as well. So complex, this is the tip of the iceberg. And so I can easily talk way too much, but I'll try to leave some time for discussion. So here we go. Let's do it. I'm going to share my screen, and we are going to hit this button. That look good? Okay, so I'm a psychologist, as mentioned, and let's jump right in. Ageism 101. What is this thing called ageism? It's almost so normal that it's invisible. It's sort of like if you ask a fish, how's the water? They might be like, what's water? Because it's everywhere. And ageism is similarly everywhere. Okay, so to define ageism, it's stereotyping, prejudice, and discrimination based on one's age. Let's break these three terms down because they're often used in ways that are less than clear or specific. And if we think about cognitive behavioral therapy, that's a model of understanding a human in their cognition, their affect, their emotions, and their behaviors. We can break these three down into those categories as well. Stereotyping is the cognitive part, positive or negative beliefs about characteristics of individuals that you are attributing to a certain group. So the belief that this person is old, therefore they must be X. Therefore they must be incompetent. Therefore they must be a slow driver, etc. So stereotyping is the cognitive part. Old people are incompetent. Prejudice is the attitudes or affect, the body, the feeling that we get about individuals of a certain group when our stereotypes are triggered. So if I see an older adult and I'm working in a checkout line, I might already be irritated by seeing an older adult in my line because I'm thinking they're going to be so slow. They're not going to know how to use the credit card machine. And I'm already feeling an affective aversion. That's prejudice. Finally, discrimination is the action that is often motivated by these prejudicial feelings that are based on stereotyped beliefs. So these are interrelated, but they're different, and they're really important to be able to tell apart. So basically, someone did not hire a woman because she was old and therefore incompetent, and I was averse to that. So that's how they can be related. It's a very socially acceptable form of bias because we do it to ourselves. If someone says, oh, you look so good for your age, and we say, thank you, two of us are colluding with ageism. Because if I said, you look so good for your race, that would be clear racism. Because it's assuming that the race that you are is normally ugly, but you somehow beat the odds. If I said, you look so good for your race, right? You look so good for your age, that means that your age is normally pretty bad looking, but you somehow are beating the odds. So you're reifying this idea that people of your age are by definition ugly, right? Or unattractive. So like other isms, it's socially constructed. It functions to serve economic purposes. The beauty industry is making a lot of people rich on fostering insecurity, right? And it helps to maintain disparity. So one nice little framework for thinking about ageism, there's 4 types that we can define as the 4 I's of ageism and other isms. And what are they? Ageism can be interpersonal between me and someone else, like when I perpetuate an ageist microaggression against someone. That's between me and an individual, interpersonal. Often unconscious, often well-intentioned. You look so good for your age, very well-intentioned. It's meant as like a compliment. Institutionalized, and that's when systems are perpetuating ageism in the differential treatment of individuals or different access to certain resources in institutional levels. And that's when doctors or other providers, they are less likely to screen for depression for older adults than for younger adults. because there's a myth that being old is depressing. So of course, if you're old, you're depressed. Sorry, that's just age. And so there's a lot less in terms of assessing for depression. And data show that when there is assessment, older adults are much more likely to be only offered medication management versus offered evidence-based psychotherapy or behavioral treatments for depression versus younger adults, thinking that older adults are not capable of learning new things, etc. So that's institutional level disparity, ageism, differential patterns of treatment. Internalized, and this is a really huge one, really important that I hope you leave sort of thinking about, is age is an interesting aspect of our intersectional identities, right? Where for many of us, certain parts of our identities are going to stay with us across our lifespan. So if you identify as a woman or a man, you may stay that way the rest of your life. I mean, of course, there's non-binary gender identities as well. The same is true for your racial identity or how you are racialized by society, or your ethnic identity. That is unlikely to change very much. So you are born and grown up into either a privileged or marginalized group based on any given aspect of your identity. If you're male and you identify as such, you are born into a privileged class in our society, and you stay in that class throughout your life for majority of folks. Age, however, is one where you are born into, and there's of course ageism against youth, but it's a very different type of ageism. But you basically internalize negative stereotypes about those other people, those old fogies out there. But then it's one of the few categories where if you live long enough, you actually sort of morph into the marginalized group. So all those stereotypes that you build up about those people start to point inward at yourself. And especially for women, that can start really early because of the societal emphasis on youth-based objectified sexuality as value for women. So, man, looking at the American plastic surgery, I forget what the actual name of the society is, they have all these recommendations for different age groups starting at 18. You know, you got to get ahead of the wrinkles. You got to get ahead of the things that are going to make you less valuable in society. So very internalized from a young age, especially for women. So they turn inward, and they often do affect and predict our health behaviors and health outcomes. So if I have heavy internalized ageism, I'm going to have the predicted health outcomes for me are going to be worse, because I'm going to think, what's the point? I'm old. There's nothing I can do. What's the point? I'm depressed. Why would I, there's nothing I can do about it. So folks with higher internalized ageism tend to have poor health behaviors and health outcomes. And of course, there's bidirectionality, but it's an important variable. And I see it with my clients and patients all the time, and it's a very important part of the work I do with older adults. The fourth I of ageism is intersectional, and that means that ageism functions differently for people based on their other coexisting identities. So ageism for women and men work differently. Ageism for a gay Japanese male individual functions differently than a heterosexual Black female. It's going to express itself in a combination and never in isolation. And so that's why intersectionality is really important, to understand the complexities of people's experience. Okay, so let's talk about ageism. Where is it? What defines old? I looked in the dictionary, right? And one adjective or one set of synonyms for old is advanced in age, broken down, decrepit, enfeebled, exhausted, fossil, grizzled, hoary, impaired, inactive, infirm, over the hill, past one's prime, senile, tired, and wasted. So if I'm old, if I'm identifying as old and these words automatically are connected in my cognitive networks, there's already that sort of heaviness of like, I am, I can't be active because I'm old. I'm grizzled. I'm past my prime. I'm kind of grizzled right now, and I'm not necessarily that old, but anyway, can go either way. Adjectives: obsolete, outdated, archaic, cast off, crumbling, decayed, hackneyed, moth-eaten, passé, relic, rusty, stale, unfashionable, and worn out. And so these are totally perfect adjectives for certain objects or things, but for humans, they can be barriers. So how does it influence these connotations influence our own use of the word old? A lot of my clients say, I feel so old. And I try to say, let's explore that. What do you actually mean? Try to be more specific. Okay, well, they feel tired. Okay, let's talk about tired, because there's stuff we can do about that. But when you just leave it at old, there's not that much to do with that, because what does old actually mean? If old is a variable, how are we operationalizing it? I think we're going to come to that. Okay, jokes and birthday cards. With old age, you acquire new skills. You can laugh, cough, sneeze, and pee all in one go. Don't let old age get you down. It's too hard to get back up. And good God, you're 40. It's a monster. And I think humor is important, of course, and it can be very helpful and beneficial in coping with things. And there are subtle ways that humor, just like racist jokes, can be reaffirming the stereotypes that really do affect people's lives in negative ways. So one way you can tell if a joke is ageist or a statement is ageist is the same way that I showed you with "you look so good for your age" or race. Oops, did I just click on something? Okay, so if I said, good God, you're a woman, that of course automatically says that being a woman is less desirable. Good God, like if you have a baby, good God, it's a girl, right? That is sexism, straight up. Good God, you're 40. It's saying that 40, you're closing your mind around what 40 means, versus 40 could be the best year of someone's life. But when we're, the ageism prevents us from having a broader idea of what is possible for ages. So businesses profit from this. So businesses, folks are continuing to make billions of dollars on ageism. So there's a lot of pressure to not do anything different. How we esteem or value others based on categories is socially constructed. So you look at the ideal or aspects of beauty in people across how it's defined across cultures and time, and we find that there's vast differences in what is considered beautiful. So it's not universal that the current sort of youth-based objectified sexuality is a sort of human universal. It is defined by culture and driven a lot by the stuff that we're exposed to on social media, on television, ads, that sort of thing. So particularly female values equated with this type of youth-based sexuality. Women as objects for men to be controlled, commodified, but beauty can be defined much more broadly. Okay, so here's some ads. Seen under normal lights, you have grandma over here, who maybe that is going to be such a fun dance party, right? But it's obviously saying that that's not where you want to go on Friday night. You want your lights to look like this, obviously 80s sort of ideal white woman, right? Juvederm, parentheses, have a place but not in your face, basically saying that lines on your face shouldn't be there. Shouldn't be there. That's a problem. Ask your doctor. It's actually something you should ask your doctor about. It's a disease, right? Aging. As young as I've learned, I've had to guard against dry, lifeless, old-looking skin. Dry, lifeless, and old, right? But as far as I know, even old people are still alive until they die, right? But old is equated with being lifeless or dead, corpse-like, right? In one aisle at Costco, this was a couple years ago now, so I should do an updated one, but I had no trouble finding tons of ageist messaging on beauty skin products. Take the next step against aging. Aging is an enemy. Wrinkle retinol correction. You have to correct the problems on your face. 25% more anti-aging ingredients. I mean, what if we said anti many things? We could say anti, and it would not be legal to print on advertisement. You want your youth, collagen back. Fight the 7 signs of aging. Sounds a lot like 7 sins of aging. So how is that different than this? So these are beauty product advertisements from different countries where colorism is much more of a very socially sanctioned thing to promote, which is whiter is better. And that's, so for smooth, fair skin, white perfect, a complete skin whitening range. Basically saying that, and I'll show you another one, basically saying that you should be like the woman who is on our right-hand side of this woman's half face. This is more beautiful on the right. The one on the left is less beautiful. This is obvious. These are obvious messages that whiter is better. That's colorism, and it intersects with racism and colonization. How are those ageist messages in advertising different? It is planting further seeds of what is beautiful and what you should want to look like. This is how ageism exists in society, one of the ways. Okay, so what are some of the myths of aging? What are some of the stereotypes that affect how we as providers might interact with a client or patient, how we might treat ourselves based on our own aging journey, how our clients might define themselves that we may never even realize. Myth: old people are depressed and being old is depressing. And by the way, at the end of this talk, I have slides with sort of data on all these things, but when I do this kind of talk, that could take forever. So you can have these slides later. I'm just going to go through the myths and tell you that data don't support these at all. They support the opposite, or they do not support that old people are all like this. So myth: old people are depressed and being old is depressing. Yes, there are depressed older folks, and that is very important to be assessing and treating. And yet the majority of older adults do not report being depressed. And it varies much more by functional status and setting. There, like depression is higher in long-term care facilities, nursing facilities versus community dwelling adults. But that's the same for any age group. If you have an institutionalized 12-year-old, you're going to have higher depression in institutionalized 12-year-olds than in community dwelling 12-year-olds. So being old does not mean you're inevitably going to be depressed, even though you might be closer to death. And that's what a lot of younger folks think that older folks are depressed about. Not true. Older folks actually worry a lot less about death than younger folks on average. Myth: becoming senile demented is a normal part of aging. False. Most older adults will not get a dementing cognitive illness that will become functionally debilitating. It's true that the risk and prevalence of these diseases increases with age, so age is a risk factor, but age doesn't cause it, because if age was a causal factor, a cause itself, a direct cause, everyone who was a certain age would have it. That's what a cause means. So age, what does age mean? It means the number of times you've been around the sun and gotten to the same point in its orbit as when you were born. That's basically what the number means. And so far, we haven't found any causal attribution of traveling around the sun with dementia we don't get dementia from being in this, going around the sun so many times. So no, that's not true. Older adults become more similar to each other as they get older. Actually, the reverse is true. The opposite is true. The older adults become more different from each other. So when you know that you have an 80-year-old on your intake form, what do you know about them? They've been around the sun 80 times. That's all you know. You can come up with some educated guesses, but to pigeonhole folks, you're likely to see a much more diverse presentation in terms of psychological and physical characteristics than you are if you took a sample of 25-year-olds, because our aging diverges in many different ways. Myth: most older adults are frail, infirm, dependent, institutionalized. Only a minority of older adults in the United States as of a 2012 national census were institutionalized. I think it was about 15%, and the majority living at home or in communities. Older adults cannot and are not interested in having sex. This is very important aspect that a lot of clinicians shy away from talking about, because there's an internalization of older adults as being physically unattractive and even repelling in certain ways physically. If folks think about their own parents or grandparents having sex, I think as kids we're pretty upset by that thought. And if in this culture, but in other cultures maybe not, because folks maybe share a communal space where it's normalized, right? But data show that many older adults engage in sexual activity, whether it's masturbation, oral sex, intercourse, other types of sexual activity. And what limits older adults is not their lack of desire as much as physical well-being is often a major limitation, and lack of available partners, especially in older women, where there's this sort of skewed population disparity between older men and older women. And that's for, of course, heterosexual women speaking there. But so we are doing a disservice to our patients if we are not asking older adults about sex and their desire, their activity. I think so. I had a 94-year-old whose husband had died, long-term husband had died 10 years before, and she had been to like her 75th high school reunion and rekindled with an old friend, and they were trying to figure out, like, okay, we haven't had sex in a long time with anyone, like, how do we do this? And so we talked about, where do you go at CV Longs to find lubricant, and what are some of the insecurities that you might want to talk about and expectations? So you're not including this as part of their humanity is doing a disservice to clients. Myth: older adults will benefit from psychological treatments. Very false. Unless someone has pretty moderate or advanced cognitive decline, older adults benefit from non-adapted CBT just as much as younger adults. And in fact, many prefer it because on average, folks over 75, I think, take it on average like 2.5 medications. And a lot of folks don't want to add any more meds. They don't, because of the side effects and potential interactions. So yeah. Myth: older adults are straight and cisgender. Hopefully folks have come across the word cisgender. Cisgender means that your gender identity, so how I identify in myself, how I feel as masculine, feminine, male, female, or any sort of spectrum or non-binary identity, how does that line up with my body parts? Right. So if my body parts are one way and my identity is going in a different way, then I might struggle with that difference, that disparity in myself. And there are, like, transgender is one sort of identity or label for folks who do not identify as cisgender. most folks who are cisgender don't know that they're cisgender because it's so privileged, because that's the norm that they get to enjoy, right? Intersex Association of America, Intersex Society of America, has really, really interesting data on physical conditions that produce babies whose genitals are neither 100% boy or girl. And combining those, they estimate that as many as 1 in 100 babies born have genital and other genitals that are not clearly one or the other. And for much of history, doctors birthing babies would actually just decide and surgically push that baby towards the direction that it was most likely or most resembling, and basically decide a baby's sex at birth with surgery. And yeah, I can imagine how when a person's hormones don't match their body parts and their identity don't match the body parts, that can be very, very difficult. Okay, what's the point of this? There are millions of gay and bisexual older adults out there, but they've had to live in most of their life in a society that has been overtly hostile to them, as well as transgender older adults. And of course, as we see in the news every day, there are still many places in this country and many other countries that are still openly hostile and intolerant. And so a lot of older adults who are gay, not straight or cisgender, are less likely to have partners. They're less likely to have families other than families of choice. Families of choice is a way of describing the folks that they've decided to be with instead of the families who in many cases had rejected them. And so a lot of older gay men living through the AIDS epidemic have lived with long-term medication treatments for HIV and AIDS, and these are important parts of their story, and so really going in not assuming heterosexuality or cisgenderness is important. Okay, another one that I hear and that is in the literature is that trainees, even and other sort of providers who don't work with older adults have this assumption that working with older adults is boring and depressing. But one cool research paper showed that geriatricians, along with pediatricians, were some of the happiest medical providers of any subspecialty. And kind of the data kind of go fly in the face of that assumption. And I find it to be never to be boring because of the complexity of working with older adults. You have physical, you have the sort of history, long life experiences coming into the present. You have, of course, mental health, family dynamics, generational, cultural, especially in Hawaii. Really, really, really fascinating. And then working with interdisciplinary teams like the one we have here has been one of my favorite things about working in this field, because everybody recognizes that we have to be humble because none of the specialties have all the answers, and so there's that humility of like, yes, let's talk together. Okay, what are we at? 33. And what do I have left? Talk about ageism in healthcare. This is sort of what we're talking about. That mental health professionals in this one study had a reluctance to work with older adults, preference against it. People were assuming that they're less interesting, poor prognosis, and less likely to benefit. In some studies, they found that physicians often ascribe physical symptoms like balance problems, incontinence, constipation, memory loss to old age instead of considering them to be potentially treatable conditions. So whenever my clients come in and tell me, oh, my doctor says my knee pain is just from old age, I say, like, do not accept that. That often for any kind of provider, when they say it's old age, it's a much more comfortable way of saying, I don't know. I don't know what's wrong. Because your left knee is actually not hurting, but your right knee is, and your left knee is just as old. So how is that age, right? Um, age is a factor, but it's not a disease and it's not a diagnosis. If it was age, then insurance would be, you could bill under age, right? But we can't because it's not a disease. Okay. Okay. So ageism is interpersonal, right? Small interpersonal exchanges based on ageist stereotypes. Often in long-term care facilities, not often, but sometimes you hear infantilizing speech, and that's called elder speak, which is use of unwanted diminutives and baby talk when speaking with older adults. Are we ready for our bath now? You want to take your medications now, don't you? There's a good girl. Hey, young woman, when this is a 90-year-old and there's a 27-year-old saying, there's a good girl, or hey, young lady, that is demeaning to a lot of older adults, even though it's, of course, well-intentioned. Use of childish names, good girl, honey, young lady, referring to elders as cute, adorable, because that dehumanizes a person to something like a caricature, right? Talking loudly and assuming hardness of hearing. Parentalism, both maternalism and paternalism as forms of parentalism are very common. Common ageist sayings, act your age, you're too old to be doing that, you look so great for your age. Microaggressions, hopefully folks are hearing about that more and more. Hopefully trainees are getting exposed to this nowadays. And this is a way of putting a framework on some of these types of interpersonal ageism that are, by and large, very, very well intentioned. But these are brief everyday exchanges that send denigrating messages to certain individuals because of their group membership. They repeat or affirm stereotypes, and they position the dominant or majority culture as normal and minority as aberrant. Often it's minimizing or invalidating the existence of discrimination itself. So you have good intentions, but your intentions don't matter as much as the impacts that you have on folks. That is often outside of your own awareness. And this is lifelong. So what kind of microaggressions? We heard some of these, wow, you have an iPhone. Wow, you look so great for your age. You're going to run a marathon? Wow, you're listening to Pink. And I realized that is already dating myself by at least a decade. You're in college, to an older person. You're still working, you have a girlfriend. Older adults holding hands, being cute or adorable. What's the next I? Internalize. This is a big one. So this is, as we talked about, it's a unique aspect of identity. We go from in-group to out-group. Those stereotypes get turned inwards. Self-stereotyping, there's quite a bit of writing on this. Sorry, I'm super congested today. And I'm trying to not let it dribble out onto my face while I talk. But the belief that senility, depression, and helplessness are inevitable, self-fulfilling prophecies. There's reduced self-esteem and often a sense of apathy. If it's inevitable that being old is depressing, why would I try? I've heard that from literally word for word. I'm old, so I'm depressed. What can I do about it, right? And understandably, that's how people with depression often feel. But when we're older, that becomes the thing to pin it on. Whereas when we're younger, we might pin it on other things about why I'm depressed and why there's nothing I can do about it. Confirmation bias is a big way that these unhelpful or inaccurate sorts of attributions start to collect momentum in ourselves. For example, of course, I'm sure many of you see older or middle adults who come in worried about slips in their memory or their perceived memory problems. And when we're younger, in our 20s or 30s, and we misplace our keys, our wallet, our phone, we don't say, gosh, this must be Alzheimer's or something, right? But even though we might do it at the same rate in our 60s, 70s, and 80s and 90s, maybe we do it at the same rate as we did when we were 20, but now we have this activated fear of Alzheimer's. And so now we start to notice it more. And we start to see things that we weren't even tracking when it may have been present for decades. So it seems to reify or falsely confirm a belief. Now, of course, there are cases of real memory loss, and that's important, but helping folks separate out which one they're going through is part of our potential benefit to them. And sometimes that involves helping teach someone about internalized ageism. I do that a lot. Can help a lot to clarify why a person is so worried when in fact the data that we're collecting from them don't suggest actual organic cognitive impairment. So this is important because it affects health, right? So in some experiments, really interesting, priming older adults for negative age stereotypes has led to even changes in walking performance, walking more sort of hunched and slowly, shuffling, deterioration in handwriting, increased cardiovascular stress. And then longitudinal study of aging, folks at the beginning of the study with more positive attitudes about aging led to higher longevity, greater longevity across the study, even after controlling for age, functional health status, gender, SES, and loneliness. So taking all the variability of those out, positive attitudes about aging still predicted differences in longevity. So older people with more negative aging self-stereotypes have higher chance of being hospitalized and have a decreased likelihood of recovering from disability. So attitudes about aging do matter. So the fourth I, ageism intersecting, varies across identities. We can't, and this really hit home to me once when I was doing a workshop on ageism for the Hawaii Psych Association, what's it called, conference, and I was talking about ageism and this, an older woman stands up and says, well, easy for you to say to not buy into sort of ageist and sexist messaging. You with, gray in your beard, like you might still get hired. Whereas me, if I go in with gray hair, I'm not going to get hired. And it's like, yes, you're right. Totally right on. And there's a difference between the valuation of men as we age. There's a sense of like, oh, there's this sort of like aging in a different way than is attributed to women, where the majority of that value is placed on that type of youth-based sexual objectified beauty. So, and my response to her, I think, was to say, like, yes. So the reality is that ageism exists, and for a lot of folks, they have to play within the system. What I hope, or what I would hope could change, is that the location of the actual problem be removed from me as a worthless old person to problems of ageism in society. Okay, I still have to dye my hair because I still need to get a job at 7-Eleven or wherever, but hopefully the locus of where the problem is transfers away from me being a worthless person to the system being set up to cause disparity. So we don't, let's see, techniques for addressing internalized ageism. Number one, it starts with looking at our own ageism and internalized ageism. That's where it has to start. When you see it in a session or an appointment, you can bring it up and name it with a person, talk about it, introduce it as an idea, provide corrective information. Actually, data don't support that older people are mostly depressed. So if you are depressed, that's encouraging because there's things we can try to do about it. Cognitive restructuring, self-compassion, pledge to become one of the many olders in training. And this comes from my favorite book on aging, which I'll definitely recommend to you. So take home messages. Age is important. Okay, I like to end on this. Respect your elders. I like words. What does respect mean? Spect, we see it in a number of other words. Spectator, spectrometer, inspector, right? To means to look. So to respect means to look again. Look, a second look beyond your initial look, which is often sort of shaped by your stereotypes of their group that you're putting them in. So look again. Not my idea of them, but actually go in with that open mind and find out if your working hypotheses are accurate. Okay, so you can email me some questions, but we can open it up to any questions or comments.
Thank you, Dr. Morgan. That was an excellent presentation. I had never heard of the 4 I's, and now I know about interpersonal, institutionalized, internalized, and intersectional. Thank you very much for that. Appreciate it. We'd like to open up to our audience. Thank you so much for attending. If you would like to share a case which highlighted any particular aspect of ageism that you would like to share, please go ahead and present a case or share any anecdote in your work experience.
Hi, Sayed. Thank you so much. I was just thinking, I just came back from the American Geriatric Society conference this last week, and one of the sessions actually talked a little bit about ageism, and they talked about how that elders speak, and they actually, somebody did a study. I can't find where it is right now, but basically the intervention was to stop doing elder speak, and what they found was that the behaviors went down. So it's really how you approach them and your attitude towards them, and they respond in kind. And yeah, if you want to reduce dementia behaviors, then yeah, you can reducing elder speak. And
thank you, Dr. Nguyen, for bringing our attention to elder speak. Thank you. Dr. Saltman, you have your hand up.
Yeah, thank you. Thank you. Yeah, and Dr. Nguyen, I agree with it. I think it's remarkably offensive when people talk, that infantilizing speech, I think it's very important for us to be aware of that as caregivers and clinicians and children, to not speak that way to our parents or to other elderly people. Yeah, thank you, Lucas. That was really good, really interesting. So I wanted to have a little case that was about my mother. My mother, when she was 96, she was living independently with some caregiving at the home, and she one day lost her balance and grabbed onto the stove, the oven door that she pulled open, and broke her leg. So this is not a hip fracture. This is kind of a lower leg fracture. And when when sort of the dust settled and she ended up with the orthopedist in the hospital, that orthopedist said something to the effect like, her longevity is only a couple of years. There's no reason to sort of go in there and be aggressive about it. And that we later find out was informed, I think he told us this, it was informed by his own mother's experience, who had broken a hip and died within 6 months of the broken hip. So that's kind of, it's kind of a bias, a personal bias like that. But it was reflected in the care that he gave my mother, and it resulted in a poor outcome, I'm sad to say. And I think that because of her age, she faced a lot of discrimination in her care in that whole setting, in a bunch of these episodes. And what's more important as clinicians and as caregivers is to sort of think about the functional status, as you said, I think, Lucas, that think about people's functional status and their, what they're really doing. And you have to, in order to figure that out, you have to really spend a minute asking the right questions and sort of looking into what their real status is instead of just their number. So that's the case I wanted to share. Thank you. Thank you.
Thanks, both Drs. Nguyen and Saltman, and I think both of what you said and shared talk about dignity, right, and trying to preserve and respect the dignity of older adults as any person deserves, but and even into their advanced cognitive decline, often folks are no longer treated with that dignity. And I think, Dr. Nguyen, that's probably where the behaviors are coming from, because even folks with advanced dementia can still feel shame. They can still feel embarrassment. They can still feel those emotions, even though there's not sort of a linguistic cognitive sort of framework to express it with. So just that respect all the way down, all the way along, so important. Yeah, thank you. Oh.
We have a question in the chat, and the question to you, Dr. Morgan, is any ideas or tips on elders who seem to be struggling with aging and refuse to seek behavioral help and even medical support? What would we do for that? Seeing increased frustration, isolation, and anxiety, how can we as healthcare professionals help these elders?
That's a great question. And it's really hard when folks are unwilling or unable to try to access other, behavioral types of supports and really sort of, even dig into a person's own ageist, internalized ageism. And I'd love to hear other people's ideas, but my first thing would be to use your relationship to encourage folks to be getting out and doing stuff, whether it's, you need to exercise more, let's think about ways to exercise socially. So they're actually increasing their activity levels, but also their social engagement, encourage folks to get involved in things that they used to enjoy, which is frankly not that different from what we would do at any age. With someone with depression or anxiety, but yeah, I mean, and validate too that we don't talk a lot about the challenges of our identity development as we age. There's a lot of focus in psychology on child development, as there should be, and yet often the interest in sort of seeing it as this norm, this sort of natural state of change sort of ends in adulthood or after your 20s or 30s or 40s or something. But we don't really talk about wow, how hard is it to get to a point in your life where different things are happening that never happened to you before, and how valid it is to struggle with that. And so even validating that can open up a dialogue to maybe this would be useful to talk about more as a window into something further. What are other folks' ideas there or experiences? Well, and I just wanted to point out another person's comment that culture can play a lot into their perception of ageism, and aging itself, right? And so the provider and the client, I think there's a variety of definitions of aging across different cultures. So yeah, important to think about that as well.
Yes,
Hey, Dr.
Dr.
Oh, sorry.
Was somebody else, Susan Christensen? Somebody else should speak before me.
Yes, I actually have a million anecdotes I can throw out there. I was trying to formulate a meaningful question. I think that in my experience, I have run into adults who are navigating ageism with their own children or their caregivers. One case that really jumps to mind is a woman who had relocated to Hawaii to live with her children because she had had a mechanical fall, had to have surgery, and then struggled in her recovery, but did get better. But her daughter said, "No, you have to come live with me now, Mom." And she moved to Hawaii, and 6 months later, she's spent 6 months sitting inside staring at the walls with no social life because her daughter and the grandchildren are going about their business, and she wanted to move back. And so she was there to talk to me about how to navigate that with her child. And I fully supported her and recommended family counseling. And then the daughter fired me. So I don't know what she refused because the mother was dependent on her for transportation. So, that was it. I don't know the outcome of that story.
Yeah, thanks, Susan. Very, very common situation, and I see it a lot where older adults are being basically infantilized by their kids, and often the adult children are well-intentioned, and it's coming out of a sense of worry and wanting to protect mom or dad, and really struggling with their own emotions at seeing mom or dad decline or change in different ways. And so they want to hold on to this idea of what mom or dad used to be. And so they try to basically put the butterfly in a glass jar. And we know how that goes, right? So I think what you did was what I do too is often, I work on assertive communication about trying to find ways to communicate what their needs are, the older adult to their, but sometimes the adult children will hear it. I do encourage to bring them in, get them on the video together. Let's all talk sometime as much as I can. But like you said, some folks are just going to put up a wall against that. So really important thing to just keep on your radar.
Thank you, Dr. Morgan. We have time for one last question. Dr. Saltman.
Dr. Morgan, can you point to other cultural settings in which the approach to aging is very different than this? Yeah,
Sure.
so much.
I think so much to say. I think in a lot of more collectivistic cultures where there's more of traditional collectivistic cultures, there were roles for older adults across the lifespan, and so there's value in and belongingness and contribution. So I think in Native Hawaiian culture, there's a value of respect for elders in the family that is a general value, and how that expresses itself in Hawaiian families can vary, of course, but looking into different cultural values can be an important source of meaning for folks, as far as developing their own positive sense of identity in later life as well. And I think that's probably been there in all cultures at some point, but I often talk about, or a lot of writers talk about ageism and devaluing older adults happening in a number of epochs in Western history, European and American, Western American history, white American history, essentially. But the invention of the printing press, because then age was not the older adult brain wasn't the storehouse of the knowledge gained, over decades. And then the Industrial Revolution, where mechanization really made a lot of folks obsolete. And so there were a number of epochs in Western history that sort of has led up to sort of where we are today in some ways. So good question, though.
Well, I thank you for an excellent presentation, and I will respect, I will look again before and be more mindful of my conscious and unconscious biases, Dr. Morgan. This presentation has been very eye-opening. Thank you so much. And thank you to all our participants. We are so pleased to have so many attendees today. You get CEs, so kindly look at this link in the chat posted by Michaela. Please click on the evaluation so you can get your continuing education credits. Mahalo, everyone, and have an awesome afternoon. Bye now.
Thanks, everyone. Aloha.